Sir, I'm putting it live on the YouTube. Now we will start it.
Okay.
I'm
fine.
trying to stay, and I can hear you now. Yeah.
Okay.
Oh, right. So we started, sir?
Yes, yes. I'll just introduce you. So, good morning, friends. Welcome back to Saturday Club morning meeting after a gap of 3 weeks because of the Diwali. So, we are happy to have Dr. Jitendra Mistry again with us. Few months back, he did give a talk on the subject of colon cancer. Now, today we'll be listening to him about inscrutable yet incredible organ, a journey with interesting cases. And to introduce him, he is specialized in pancreatobiliary and GI surgery, GI cancer, and liver transplant. He works with the Institute Mission Gastrocare Vadodara. He has, to his credit, several awards and several publications, 34 in number to be precise, presentations in conferences. He is reviewer of journals. He is member of editorial board of several journals and contributor of chapters to several books. So with this little formal introduction of Dr. Jitendra Mistry, I request him to start his presentation. Because of some technical snag, he is not able to put it on a slide, so but that is okay. Dr. Jitendra, you can start the session.
Thank you, sir. Thank you for the introduction. Thank you, everyone, and good morning to everyone. So today I'm talking about an organ which is, to me, an inscrutable, despite a lot of advances. But if you go into the detail, it's an incredible organ to deal with. It is an organ which is very close to my heart, and I would love to operate on this organ. So I'll be presenting some detail about the evaluation of the knowledge of that particular organ with few cases as well. So when we see a patient like this who comes to us with ascites, he says that he's chronic alcoholic. He has several episodes of GI bleed, and then the sonography or radiology or blood investigation says that the liver is an end stage.
Dr. Jitendra, your slide is not moving. I'm seeing only the first slide, the title slide.
It is actually moving here, sir.
What about others? Are you able to see the other slide or only the title slide you are seeing?
No, not others.
Only title slide.
So again,
Not moving. Not moving.
Okay.
Is it moving now, sir?
No, we are only seeing the first slide. So what probably you can do is now click on the left panel and see whether it is changing or not. It's not. Yeah,
Yes,
now it's changing.
Now it is
So now we can see the other slide, the inscrutable part.
Yeah.
yeah.
Okay. So I think when I screen share, I do a slideshow mode. It doesn't work some way. So I'll keep on this mode only.
Yeah, keep on this mode and keeps clicking on the left panel, so we will be able to see the slides.
Okay, fine. So the only problem will be whatever animations I have done will not be able to do it. But anyway, fine. So basically, when we see a patient with ascites and end-stage liver disease, we feel helpless. We have, for example, dialysis for a renal failure or a pacemaker for a cardiac issue or a ventilation for a lung failure. But we are yet to develop a machine. We can put on the patient on that machine and say that it will completely replace the liver and we can buy some time. So that is how liver is inscrutable. Or when we see a CT scan, which has a large liver mass, or when we see a patient with colon cancer and who has 2 or 3 metastases in the liver, we feel that it's the end of the day. Or when we think about the liver surgery, immediately the vision comes into our mind is like a blood of pool. So liver seems an unscrutable despite lot of advances. But if we go into the detail, it is one of the very incredible and a kind organ. If you go into the history, people have believed that liver is a center for soul and life. It is an era before we came to know about lungs or heart. Even certain ethnic groups in certain area, we used to say that you are my liver, or I miss my liver to that loved one. The way we see right now, the way we say right now that you are my heart. So it was actually a comparable to heart in the past era before the heart and lung came into the picture. Actually, there is a reference in the literature where Prophet Muhammad used to use the word moist liver to refer to the soul. So yes, liver has been given a lot of importance in the history as well. If you go into the recent past, in the 19th century, there were liver pills available over the counter in the countries like UK and US. There was something known as bile bean or a cartel's pill, which were over-the-counter pills available in those countries, and those pills were used to believe that they increase the liver health without any significant evidence. And a lot of companies have made millions out of this. When we have our own Indian version for the liver pill as well. So yes, even today people believe that there are pills available which can detoxify or which can improve the liver health. And so even for the lay people, liver is significantly important, even if scientifically those are not well proven. Now we talk about the liver surgery. Before 19th century, liver surgery was mainly for trauma. So when the liver is contused or there is a laceration in the liver, a segment of the liver has been separated, the surgery includes the removal of those segments and some hemostasis, that's all. The elective surgery was not in the vogue before 19th century. In 19th century, some brave surgeons started doing an elective liver surgery, but with a very high mortality. Mortality was ranging from 30–40% in that era. From 1950 to 1980, a lot of people have progressed about understanding the liver, but the practical applicability was little less. After 1980, the liver surgery has progressed so quickly and so fast. Another reason probably is that from 1980, the ultrasound came into the vogue in a big way. And that is how more and more number of liver lesions started detection. So understanding of our liver is very important. The biggest challenge in that era was control of bleeding. So people used to cut the liver to remove the diseased part, but liver used to bleed profusely and it was difficult to control. And patient used to die on table or immediately post-op because of the bleeding. But then people investigated a lot, people researched a lot, and they realized that liver is not just a piece of meat, but it's a parenchyma with a lot of blood vessels inside. So the liver structures, we came to know a detail about liver structures, and that is how the liver surgery changed. So the most important part in the liver structure is that there are three structures which enters into the liver. That's the bile duct, portal vein, and hepatic artery. But even more intricacy which lies into the internal structure of the liver. A lot of people who have done a lot of research to understand the internal structure of the liver, and one of the very big name among them is someone known as Conard. The Conard was a French anatomist and a surgeon which studied a lot of liver cast and came to know. He depicted a detailed internal anatomy of the liver. He came up with a detailed anatomy which says that portal vein and hepatic artery enters into the liver, and there is a definite pattern of its distribution inside the liver, and there is a definite pattern of the venous drainage from 3 hepatic veins into the inferior vena cava. So based on this vascular distribution inside the liver, he gave the segmental anatomy, and he divided the liver into 8 segments based on this vascular anatomy, which is true even today, and based on which the liver surgery has progressed massively. So there are 8 segments of the liver. Segment 2, 3, and 4 is the left lobe of liver. Segment 5 to 8 is the right lobe of liver. And this vascular distribution is more or less constant. So if we if we understand this anatomy, if you understand this internal structure of the liver surgery is very easy. Liver surgery is probably the one of the surgery where you can get the result on the table. If you do on the table on the operation theater well, patients generally do well. That is, if you look at the other surgeries like Whipple's procedure, even if you do a surgery good, your pancreatic anastomosis will decide the outcome. But in liver surgery, whatever happens on the operation table. If on operation table the things are done well, generally the result is good. So this segmental anatomy, even we can make out on the radiology also. So before going for the surgery, we need to have a good quality imaging, and based on that imaging, we can come to know every detail of the liver, the vascular structure, the anatomy, the abnormality of the anatomy, and every segment. We can even come to know which segment is involved and which segment we have to remove. So yes, the segmental anatomy given by the Conrad and the 8 segments mentioned by him has changed the liver surgery massively, and the liver surgery has become possible today in the present situation. So anatomically, we understand that right lobe of this is the falciform ligament, and the liver left to the falciform ligament is the left lobe, and the liver right of the falciform ligament is the right lobe, but which is not true. As per the Conrad, the line which joins from the gallbladder fundus to the inferior vena cava divides it into the right liver and left liver. And this is actually a correct anatomy from surgical standpoints. So coming to the first case, we have is a 67-year-old female patient who came with an abdominal pain and lump in upper abdomen for 2 months. She also had anorexia and weight loss. She was diabetic. She was hypertensive. She has a dyslipidemia, and she was on antiplatelet medications. The ultrasound and CT was done somewhere else, which showed a large left lobe liver lesion. Someone advised the biopsy. So when patient came to us, we did a triphasic MRI. And in triphasic MR, we could see a large left lobe liver lesion. So the lesion was completely replacing the segment 2 and 3 of the liver, and it was not involving the segment 4. So that means that the whole left lobe is not involved. I have particularly highlighted the word triphasic liver scan. Now, every organ has its own blood circulation dynamic. If we exploit this blood circulation dynamic through a radiology, and we take the radiology CT scan or MRI cut at that particular area, that particular time, that will give an amazing detail of the tumor and the normal liver. And that is why a correct advising the correct form of CT scan is very important. Every organ we have there is a different type of CT scan or MRI, and if we follow the correct phases, it will give an amazing information. Every monthly we see 1 or 2 patients where CT scan is done showing something else, and when we do a perfect protocol CT, it changes the diagnosis and prognosis completely. So yes, advising the correct imaging is very important. So this patient had a tumor in the left lateral segment of the liver. Now somebody advised the biopsy. Do we really need biopsy in this case? Here I would like to put a blanket statement that any HPB malignancy, any hepatopancreatobiliary malignancy, if there is a clinical and radiological features are convincing for a malignancy and the lesion is resectable, you actually do not need biopsy. This is a very blanket statement, but this is very true. If you have a 50-plus-year-old patient with a jaundice, obstructive jaundice, bilirubin of more than 10, and CT scan is showing a pancreatic head mass, which is the enhancement of that mass is like a malignancy, it is a pancreatic malignancy. It doesn't need any biopsy. If it is resectable, it never needs a biopsy. There is a definitive and specific indications for biopsy. For example, if that lesion is unresectable and you are planning for a palliative chemotherapy, or you are planning for a neoadjuvant chemotherapy, then you need a biopsy. If your radiological and clinical features are not convincing of malignancy, you need a biopsy. Or if you're suspecting something like tuberculosis or lymphoma, where the management is medical, you need a biopsy. But if your clinical features and radiological features are convincing for malignancy and the lesion is resectable and surgery is the treatment of choice, you never need a biopsy. You should never advise a biopsy in such situation. So looking at the tumor location, the round circle is the tumor. So it involves the segment 2 and 3 of the liver. It does not involve the segment 4. So this patient we planned for a left lateral segmentectomy. So the resection will take place from here, and this area would be removed. When we open the abdomen, this is the operative picture, a large left lateral segment liver lesion, which is vascular, which is definitely a malignancy. Now, when we opened the abdomen, there was a surprise. The surprise is that this is a falciform ligament. This is a primary tumor, but there are few nodules, the sub-centimeter nodules in the segment 4 as well. So now, when we planned, in this case, the left lateral segmentectomy from here, but the segment 4 is also involved. So we have to do a left hepatectomy in this case. So we have to be ready for the surprises because CT and MR has its own limitations. Sub-centimeter size nodules, 1 or 2 millimeter size nodules may be missed in any form of investigation, any form of radiological investigation. So we planned for the left hepatectomy. Now, based on the canard anatomy, if we control the inflow, the blood inflow in the beginning, the blood loss or the bleeding during surgery is quite less. So we dissected the porta, the blue sling, which is looping the left portal vein, and the left sling, which is looping the left hepatic artery. So we have to remember here that it is one of the organ which has a dual blood flow. It gets the blood flow through hepatic artery as well as the portal vein. And you would be surprised to know that on an average, 1.7 liter of blood flows through the liver, and the 1.7 liter of blood gets filtered through the liver. And it actually solve another purpose, that all GI malignancies, the cell filters through the liver, and that is why all GI malignancy, if they metastasize first to the liver and then have a systemic metastasis. So that is how, even with a GI malignancy primary and one secondary in the liver, is also considered curable or resectable in many malignancies like colorectal malignancy. So liver also filters the blood, liver also do a lot of metabolic work, and liver also filter the malignant cell and keep confined it within the abdomen and makes the surgery possible, even if it's a metastatic malignancy in some of the selected cancer. So liver has an amazing role in the body. Now, once we control the inflow, so here the left hepatic artery and left portal vein is ligated. If you watch carefully, you can see the ischemic line, the transection line. So liver itself will tell you that here you have to cut, right? So that is so the left lobe of liver has become dusky, has become ischemic, it has become dark. If you see the right lobe is well pink, so there is a ischemic line, the transection line between, and through that transection line you have to cut, and there will be a lesser blood loss. So that's a picture which is a transection in progress. So that's the right lobe of the liver, that's the left lobe of the liver, that's the falciform ligament, the segment 4 which has few nodules, and left lateral segment which has a tumor. So this right lobe will remain inside the body and left lobe will remove. And that is a final look at the end of the surgery. So the left lobe with the tumor is out of the body now. The clamp which is applied to the left hepatic vein, which will be sutured, and that's the right lobe, the remnant liver, which will stay inside the patient's body. So the operative time for left hepatectomy was around 4 hours. Blood loss was 300 cc, and there was no transfusion required. I don't know if I can play this video. Okay, I'll play from here. So this is an orientation of the left.
We don't see the video playing.
Okay, okay. So I'll just
You can skip that part, yeah.
fine. Okay, so we did a left hepatectomy, and the left lateral segment, that is segment 2, 3, and segment 4, which we removed. So that video actually was showing orientation of the specimen. It was actually for the pathologist as well. So the postoperative course was uneventful, and patient was discharged on post-op day 6, and the biopsy was well differentiated multifocal hepatocellular carcinoma. Now, somebody may ask the question that what will happen to the half of the liver which remain inside the body? As I said, it's a very incredible organ. It is probably the only organ, if we exclude the skin and mucosa, it is the only organ in the body which can regenerate, which can regrow. So if you repeat the CT scan after 3 to 6 months, you will find near normal liver volume in patient body. So liver will regrow and will enlarge and will satisfy the need of the body by regrowing and regeneration. So we can cut a lot of amount of the liver in patient, and nothing happens because liver generally regrow. Coming to the second case, here the patient is 63-year-old male who came with an anorexia, weight loss, and abdominal pain. There was no comorbidity, and CT scan elsewhere done, which showed a right lobe liver lesion. We did a triphasic CT abdomen here. The triphasic CT showed a massive tumor in the right lobe of liver. The right lobe of liver was completely replaced by the tumor. To simplify the thing, the blue circle is a right lobe liver mass, which include the whole right lobe of the liver, which is segment 5, 6, and 7, 8. It was actually a little bit of going into the left lobe segment 4 as well. So we planned for a modified right hepatectomy. I say it modified right hepatectomy because the right hepatectomy transection line would be joining from gallbladder to IVC, but because tumor was slightly going into the left lobe, you have to take about 1 or 2 centimeters of the left lobe of the liver as well. So that is how it's a modified right hepatectomy. This is an operative picture, right? So we can see that's a gallbladder, that's the liver, that's the right lobe of the liver, that's the massive tumor. The routine transection line in the right lobe of liver passes through here, but we have to transect slightly on the left side to get the tumor margin. In this case, the surprise was that the right lobe of liver was infiltrating a little bit of part of the peritoneum of diaphragm as well. So we planned for the right hepatectomy in this patient. That's the operative picture. The inflow is being controlled, which is the most important thing in liver surgery. So various slings have encircled the loop, the various portal structure, the inflow structure. So this blue string is a main portal vein. The right side blue string is a right portal vein. This is a right hepatic artery. This is a left hepatic artery, and the yellow sling is bile duct. So all portal structures are dissected and looped. If we control the inflow well, the bleeding during surgery is minimum. So we ligate the right hepatic artery and right portal vein here, which will make the right lobe ischemic, which will give us the transection line, the ischemic line, and the blood loss during the transection would be low. So that's the transection in process. So we have started transection here rather than transecting at the actual transection line. So once we start the transection, now the question is, how do we transect the liver? So there are various methods, right? In past, actually, people used to just transect the diseased part, and then the liver used to bleed a lot. Then a person called Kim from the Korea who invented the technique called finger fracture technique. So with the thumb and index finger, he compresses the liver parenchyma, he disrupts the liver parenchyma, and you palpate the vascular structure inside that parenchyma, and you ligate those vascular structure, and that is how blood loss can be reduced rather than just cutting the vessels and then trying to do an hemostasis. But the finger fracture used to disrupt a lot of liver parenchyma, and a lot of liver tissue used to be get wasted. So then somebody came up with an idea of caliclysis. So rather than using a finger fracture, the thumb and index finger, he started using artery forceps. So with the artery forceps, they compress the liver parenchyma, they disrupt the liver parenchyma and identify the structure. The hepatocytes are disrupted. Only the arterial structure or venous structure is identified. They ligate the structure and then they cut the structure, and that is how blood loss is less. Then somebody came up with an idea which is called a CUSA, an ultrasonic aspirator. So this is an ultrasonic energy-based device which actually aspirate the hepatocytes and keep the vascular structure intact. And so that you ligate the vascular structure and then do a surgery, which is even more precise than the caliclysis, but it generally takes a little longer time than the caliclysis technique. But it is important when the volume is a crisis. For example, if you are doing a donor hepatectomy for liver transplant, the CUSA is very important because the parenchyma loss is very minimum and it is more precise. But if you do a surgery for tumor and when the volume is not so much of crisis, then caliclysis is a faster technique. So caliclysis is one of the commonest used method. A CUSA is the next commonest used method for the liver transection. The water jet dissector is also works on the same principle. With the water jet, they disrupt the liver parenchyma, which keeps the vessels intact, which skeletonize the vessels, and we transect the vessels. So we ligate the vessels and cut the vessel. So in the second case, that's a transection going on. So this is a right lobe of the liver with the tumor, and that's a left lobe of the liver, which will stay inside the patient's body. So transection is almost 1/3 of the liver parenchyma has been transected now. So that is a final picture. So right lobe of the liver with a tumor is now out of the body. That's the left lobe of the liver, which will stay inside the body. That's the white star, the cut surface of the liver. The white arrow, which is showing the inferior vena cava, which has got exposed at the end of the right hepatectomy. The blue star is a right kidney, and the red arrow, which is actually a diaphragmatic peritoneum, which we have excised along with the tumor because the tumor was involving that part of the diaphragmatic peritoneum. There is also a specimen orientation. The video is not playing, so I'll go just further. So the operative time in this case was 4 hours. Blood loss was around 400 ml. We did not transfuse any blood. 300 to 400 ml of blood loss is very well tolerated in a patient whose preoperative hemoglobin is more than 10. So we generally do not transfuse up to 300, 400 ml of blood loss. This patient was discharged. This patient is being discharged today. Actually, today is post-op day 8 and biopsy is awaited. Going to the third case, which is a 50-year-old male patient who presented with dull, non-specific pain on the right side of the abdomen for last 3 months. There was no significant anorexia or weight loss. There were few normal ultrasonographies, but one of the last ultrasonography, the radiologist pointed out something in the right lobe, probably a developing abscess or something. So patient went ahead for the CT scan and MRI. We did a triphasic CT and MRI. So if you can appreciate the segment 6 of the liver, there is a 3 or 4 centimeter size tumor in the segment 6 of the liver. That arrow is showing the segment 6 of the liver. That's a tumor. Now, if we in a triphasic CT abdomen, we can see this is a main portal vein, which is divided into the left portal vein. Here, there should be a right portal vein, but right portal vein is not seen in the picture because the right portal vein is involved in the tumor. So right portal vein and right hepatic artery, both are within the tumor. If you see carefully, there is an indentation into the confluence of the portal vein. So that means that the tumor thrombus or tumor is protruding inside the lumen of the portal vein at the confluence. Now, many people think that if right portal vein and right hepatic artery is involved and the main confluence of the portal vein is involved, this is an unresectable tumor, but that is no more true now. Even the vascular structure involvement, we can resect the tumor. So in this patient, basically tumor is here, but we cannot resect only tumor in this case because the right side vascular structures are also within the tumor. So we have to cut the right portal vein and right hepatic artery. So that means to remove this tumor, we have to do a right hepatectomy. As the portal vein confluence is also involved, we have to resect the portal vein confluence along with the tumor, and we have to anastomose the left portal vein with the main portal vein. The hepatic artery confluence is not involved, so we do not have to resect the hepatic artery, but portal vein confluence is involved. So we have to cut the portal vein confluence and we have to anastomose the left portal vein with the main portal vein. And that is how this tumor becomes resectable. Because the tumor was involving the bile duct confluence, we have to excise the whole extrahepatic biliary tree as well. So it will be a modified extended right hepatectomy. The hepatectomy, it is not just a right hepatectomy, a part of the left lobe we have to take with the tumor because the biliary confluence is also involved. So it's a modified extended right hepatectomy. Now somebody may ask that how much volume we can remove. As I said in the beginning, although it's an inscrutable organ, it's an incredible and very kind organ. So if the liver is normal, we can remove up to the 75% of the liver. Only 25% of the remaining liver inside the body is enough for the body. But we have to leave 5 to 10% of the extra liver for a margin of error. So if anything is more than 35 or 40% remaining inside the body, it is safe. But the remaining liver should be well vascularized and well functioning. So normally the right lobe of the liver generally consists of 55% of the total volume, and the left lobe include the 45% of the liver volume. So if you do a right hepatectomy, we generally remove the 55%, left lobe is generally enough. If you do a left hepatectomy, 45% is removed and 55% will remain inside the body, which is also enough. So for the right and left hepatectomy, volume is generally not a problem. But if you have to do an extended resection, so if you are doing an extended right hepatectomy and we are taking a part of the left lobe as well, we have to be careful for the liver volume. So can we measure the volume? Yes. So based on the CT scan, there are softwares available which will tell you exactly how much amount of liver is going to stay inside the body. So it can measure the total liver volume, it can measure the right lobe volume, left lobe volume, tumor volume, even you can measure the segmental volumes as well. So it is known as CT volumetry. So we have started doing CT volumetry in Vadodara because we have started doing a liver resection surgery. So volumetry and exact volume can be calculated and can be counted, and we come to know exactly what amount of liver remains inside the patient's body. Now, if the remaining liver parenchyma is not enough, can we manipulate the volume of the liver? Yes, we can manipulate the liver volume. For example, this is the tumor, and we have to do an extended right hepatectomy, and the remaining left lobe volume is not adequate. It is 25% or less than 25%. What we can do is we can do a portal vein embolization on the right side. The side of the tumor, the side of the liver which we have to take out. If you do a portal vein embolization, keep the hepatic artery intact, but we embolize the portal vein, the blood, excessive blood will flow to the left side. And over a period of 2 to 4 weeks, the left lobe of the liver will enlarge, will grow, will hypertrophy. And after 2 to 4 weeks, we do a repeat CT and we see the remaining volume is high, we can do a surgery. The same thing can be done with the surgery, which is known as an ALPS procedure, where we transect the liver, we transect the right portal vein, we close the abdomen. After 9 days, we repeat the CT and we'll see that there is a hypertrophy of the left lobe. We can again go in and the transected liver, we can take it out. So yes, liver is an amazing organ. If we follow certain rules, it will help us, it will allow us to do such kind of maneuvering, and we can remove a large part of the liver without compromising the life. So this is the patient with the tumor with which involves the portal vein confluence. So we can see in the picture the white arrow is a tumor. The blue sling below is a main portal vein. The blue sling on the left side, it is a left portal vein, and the tumor is involving the portal vein confluence. So we have to cut the portal vein here, and we have to anastomose the left portal vein with the main portal vein. So that is the white arrow which is showing an anastomosis between the left portal vein and main portal vein. And once we ligate the right portal vein and right hepatic artery, we can see the ischemic line here, the dusky part which we have to remove, and the normal part on the right side. So we started the transection here. So that's the transection in progress. So that's the transection, that's the right lobe with the tumor, and that's the left lobe which will remain inside the patient's body. So that's a near complete transection. Right lobe we are transecting. That's the left lobe. That's a sling which we generally put, which is known as a hanging maneuver to lift up the liver and which will help us in the transection. So that's a complete picture. So right lobe is completely out. That's the left lobe. That's a large cut surface of the liver through which we have done the transection. As in this case, we excise the whole biliary tree, only left hepatic duct remains. So we have done a Roux-en-Y hepatico-jejunostomy with the left duct as well. The left duct size was 2 or 3 millimeter, but we can do a hepatico-jejunostomy with such a small bile duct size. So in hospital course, this surgery took 10 hours to perform because we had to extrahepatic biliary excision, we have to do a portal vein confluence excision, and then anastomose the portal vein. So the blood loss was around 800 cc, and we transfused 1 unit of blood during surgery. Post-operatively, this patient had a small collection near the cut surface, which we managed conservatively, and patient was discharged on post-op day 12. The biopsy was intrahepatic cholangiocarcinoma. The next question may arise, that is there any role of laparoscopy in liver surgery? This is actually a video which showed laparoscopic surgery for liver hemangioma, but I think I cannot share the video. I'll just try to share the video if it is possible. Can we see the video, sir? Can we see the video, sir?
Not yet, not yet.
No.
So is it playing? Is it playing now?
No, I think your screen sharing is not properly working because we are not seeing any. What
Okay.
we are seeing is your
Okay.
window where it is showing some video clips, etc. But it's not opening for us.
Okay, fine. So I think I'll not be able to show the video here, but yes. So we have been doing the laparoscopic surgery for liver as well, but for the limited resection, for example, left lateral segment or a small tumor at the superficial part of the liver or edge of the liver, we have been doing the liver resection laparoscopically. The major right and left hepatectomy laparoscopically, we are not doing it. There are centers across the world, few centers across the world, those who are doing routinely laparoscopic liver surgery. So yes, laparoscopy has a role in the liver resection as well. This is my last slide. So I would summarize by saying that liver is an inscrutable organ because we yet to have replacement which can completely replace the work of the liver. We can there are a lot of research in the progress which are trying to develop the biological liver or the machine which can replace the work of the liver completely, and we can put the patient like we put the patient on dialysis, and so we can buy some time for the definitive management, but we are yet to succeed in this part of the science. Another problem with the liver is that it's a very vascular organ and it can bleed to death if you do not follow the rules. If you mess up with the liver, it's a very dangerous organ. But still, if you follow the rules, if you understand the liver well, it's a very incredible and kind organ. The 25% of the liver is enough. So if there is some disease which needs a 75% of the liver resection, we can remove it and still the patient can survive. Liver can regenerate and regrow. We can manipulate the volume as well. So playing by rules, we can do any complex surgery and it can help the patient. Everything is possible if we play by the rule and we understand the liver structure, anatomy, and physiology well. And another take-home message I would like to give is that the liver lesion rarely needs biopsy, except in certain specific situations. We should not advise routinely biopsy if it is a malignancy and if it is a resectable. And liver metastasis in some of the malignancies like colorectal malignancy or genitourinary tract malignancy, it is still resectable. It is not the end of the world. So malignancy with the liver metastasis, we should not straight away reject the patient for a potential curative treatment. So that is all from my side. Thank you very much. And I'm extremely sorry my slideshow is not working and I could not show some interesting videos.
Thank you, Dr. Mistry. You can stop sharing the screen now so that we can interact.
Yes,
Yeah,
sir.
in fact, today morning at 7:30, me and Dr. Jitendra started the meeting and he tried his best to get the full slideshow, but somehow he couldn't. So anyway, there are some comments and questions in the chat box that I'll take up first. Dr.
Yes.
Sulin has made a comment that is it like hepatic malignancies most of the time secondary? If so, by removing liver portion, what about primary malignant site left alone? He has some confusion, so he's asking about
Yes, sir.
secondaries in the liver.
Yes, sir. Yes, sir. So the commonest liver malignancy is generally secondary. So, in certain selected cancers, as I said, in colorectal cancer or in genitourinary tract cancer, even if it's a liver metastasis which is resectable. So the primary which is resectable and the secondary which is resectable, yet you can have a curative approach and you can resect. So obviously, when there is a secondary we are resecting, obviously we have to resect the primary as well. But the second most common tumor in the liver is its own primary, which is either hepatocellular carcinoma or intrahepatic cholangiocarcinoma. So in cases where we have done a liver resection for secondaries, we have also resected the primary. And for the primary tumor, we do only liver resection.
Another question from Dr. Sulin is about liver. Cut surface of liver may not be smooth after surgery. Does it function as normal? Liver kind of derange LFT, and what about bleed from cut surface? So he has doubts about functioning of liver when it is subjected to some surgery and about how we control the bleeding during surgery.
Right, sir. So basically both the things is well explained by the structure of the liver. As I showed in the one of the slides that Connaught gave us 8 segments, which has its own blood supply, which has its own biliary drainage, which has its own venous drainage. So if you follow this rule, the remnant liver will function normally. And as I say, 25%, anything more than 25%, it is enough for the body. So cut surface, the remaining part, even if the cut surface appears raw, that part has well vascularized and well functioning. So the remaining part is more than 25%. It works as a normal liver. The bleeding from the cut surface, as I said, when we transect, in the past, generally they used to transect blindly, but now we do not transect like that. We disrupt the liver parenchyma. Inside the liver parenchyma, we identify the pedicles, we control those pedicles, and then we further transect. We keep on repeating these steps, so blood loss is not much. Some of the minor blood loss from the liver cut surface can be cauterized or bipolarized. There is also special instrument available, which is called argon plasma coagulation, but generally it is not required. And sometimes we put something like Surgisil or Abgel on the cut surface to control the minor bleeding. But yes, with the following certain set of rules, the liver cut surface doesn't bleed, which we generally think.
So one more interesting question Dr. Sulin has asked about how does it stop regenerating? At what point the liver will stop regenerating after it is cut?
So nature is amazing. I mean, basically what happens when we remove the right lobe of liver, the amount of blood flow through the portal vein remains the same. So whatever blood flow was going to the right lobe is now going to the left lobe. So left lobe is getting the extra nutrition, extra things, and that is how it starts regrowing. But up to a certain extent, after that blood flow is enough for a certain extent, they stop regrowing. So it's the nature which adjusts the requirement.
Thank you. And Dr. Pradeep Seth has made a complimentary comment that simple but important points effectively made. So I also agree that you started with the title Inscrutable Organ and you tried to make it quite scrutable for commoners like us. So thank you very much for that. Now, any other comments and questions are welcome.
Yeah. Congratulations, Jitendra. You are doing a wonderful job.
Thank you, sir. Thank you, sir.
You should be ready for a hepatic transplant now.
Yes, sir.
Can we do it in our children?
Sir, yes, it is in my mind. I mean, obviously, transplant is a well-developed program across the country now. The only problem with the transplant is that it's not a job of single person. So we need a whole lot of team, which include the hepatologist, the transplant surgeon, the kidney specialist, the dialysis, specific liver ICU, blood bank within the hospital. So
We
everything
have
is available.
everything.
Yes, sir. But then another problem with the liver is that we need a bigger team, because majority of the transplant in our country is living down a liver transplant. So 2 surgeries are going on simultaneously. So you need 2 transplant surgeons operating in 2 different OTs, and the other teams also, which know the detail about transplant. So yes, definitely it is possible, and it is in my mind. But let's see. What we can do.
I agree with Dr. Jagdish Bhai's, comment and suggestion that why is Baroda lagging? I mean,
Yeah.
Ahmedabad can do it, Delhi and other places can do. Why not we? I mean, we
Yes,
have
sir.
excellent people like you, so all efforts to be made to make a team and do it.
Yes, sir. Yes, sir. Definitely, definitely. So I am trained from Gangaram Hospital, which is probably one of the most well-developed and the high-volume transplant center in the country. When I was doing DNB, they used to do every alternate day 1 transplant. But the team consists of at least 12 to 15 people. So everybody know everything, and that is how actually. So the hospital which can invest for 10, 12 doctors is actually difficult from the return of investment point of view for majority of corporate hospitals in the city. So that is the problem actually for development of transplant in city. But obviously somebody will take up the challenge, and definitely it will become possible.
So pediatric transplant is a very far off possibility in Baroda.
Oh, definitely, sir, definitely. And it's not that difficult, which we believe. But yes, we have to make a bigger team.
Any other comments or questions from anybody? No, I don't see any hands raised. So thank you once again, Dr. Jitendra, for
Thank you very
very
much.
elaborate and simplified talk on this difficult topic, I would say. And thank you all for joining us in Saturday Club. Now, next Saturday, we have our Gujarat IMA conference. So as Dr. Jagdish Bhai had suggested, we will not be able to conduct this meeting.
Yes.
So we'll meet again on 26th of this month. So thank you all and bye.
Thank you, everyone. Thank you.